Um, so, I mean, theoretically, we could go over something, but then I can't really set it in stone because, like I said, some people have to be at work at 2:30 when your scheduled time is from 2 to 4. So let's just, after this aortic lecture, let's go over any questions anybody has, because the quiz is going to be over the color Doppler. It's going to be over pulse wave and continuous wave, mitral valve, tricuspid valve, and aortic valve. Anything that's on those PowerPoints is fair game.
Tammy,
Yep.
are we meeting for class next Monday or are we just having a quiz?
It'll just be a quiz.
Okay, thank you.
So whenever we have scheduled quizzes, which I'm trying to get 2 quizzes in before your final, because the more quizzes I can give you, the better chances you guys will pass the class, because it's not just one giant final. So it'll be during the scheduled class time so that you guys don't have to think that you have a quiz on another day, when I really am only scheduled to have you guys for 2 hours on Monday.
So the final is an accumulative final?
Yep.
Okay.
Yeah. So it'll be over everything. Okay. So again, I'm just going to go over, kind of brush up over the specifics that I want you guys to know. I'm not going to read every slide word for word. Basically, I lost one of my, the main errors that we have when we're trying to get a peak aortic velocity is the Doppler angle. People just throw the Doppler across the aortic valve and think it's going to be a true velocity. You have to be as parallel as you can be in order to get an accurate measurement. So super angle dependent. Make sure that you open up that left ventricular outflow tract and you line it up. With older patients, the hearts begin to kind of form a little bit differently, and it can kind of have an angle to it. So just, if you can't get parallel to flow, don't record it, because it's always going to be an underestimation of the actual velocity across that aortic valve. Things you can do to improve the angle: roll the patient. I know a lot of you guys in the adult world will roll them more up on their side. Not always is rolling up on the side the best. Sometimes rolling them a little bit more on their back can work too. When you have really kind of obese patients, sometimes it works to lay them on their back. So just kind of play with that. On each patient can be a little bit different. Roll them on their side, roll them a little more to their back. I always tug down on that rib. I always feel that if I can rest my transducer on that rib, it brightens things up, and it actually will open it up better for you. Again, if you don't get that LV outflow tract completely open, your measurements are going to be way off. So that's one of the biggest problems with being a sonographer is don't always just take your first picture when you throw color across and you see it. Just make sure that you're as parallel as you possibly can be. Can't. Hold on a second. I try to move you guys and then my slide changes. Okay, so measuring artifact. I was showing some of you guys today. Basically, don't be overgained. Turn down your gain. In pulse wave, we like to see a window between the actual tracing. It's not going to be totally filled in like in a continuous wave. So we turn down that gain, and turning down that gain is going to get rid of all that wispy stuff. And then it'll be easier for you guys to measure than seeing a whole bunch of bright, just blurred out tracings. Again, what's that?
Sorry to interrupt, but can you resend today this PowerPoint, because I never got it?
This is Nancy, right?
Kathleen.
Kathleen, crap. I don't know your voices very well. All right, Kathleen, I will send it back to you. Are you the only one that didn't get it?
I don't know. I was just checking my email and checked my junk.
Kathleen, I got it in Canvas, actually. This is Nancy.
Mine's on Canvas also.
I had to find Canvas too.
Yeah, I did post it to Canvas. So Kathleen, can you see on Canvas?
Okay. Sure, I'll check in Canvas. It's probably there. I've just, since, yeah, anyways, No
I
problem.
think yeah, I just realized it's probably easier to put it in Canvas because some people can get it, some people can't.
I have a question, Tammy.
Yep.
Going back to the correct Doppler angle, you mentioned in your slide somewhere that it's almost always an underestimation. Is there ever a time where you overestimate the severity? Because that would be putting a patient in a category that would, put them in a TAVR type situation.
True. Only if you're overgained and only if your tracing's erroneous.
Okay.
So that's why it's really important to gain that down. A lot of times, I mean, when it does come down to that, they take the patient to the cath lab. We as echo techs seem to overestimate a lot of times because we kind of like to incorporate so much, and we almost like to seem to want it more severe than it is. So the cath lab usually will always, they always tell us, you guys overestimate. So just make sure not to incorporate all that wispy stuff. Okay.
Thank you.
Yep. And again, at least on the machine I have at my work, when we do tracings, we have a auto LVOT trace. When we hit it, it traces 3 consecutive pulse waves, and then you can tweak its specificity and kind of bring it down a little bit. So when in doubt, if you have a bunch of kind of a little bit different waveforms, it's best to do 3 and average them. If you're questioning the severity of something, we do like to do more than one measurement.
And that's typically how it goes with most spectral tracings, right? Is the machine will automatically take 3 anyways. We just work with machines that are a little bit older here.
Yeah, my auto LVOT always takes 3. And then the other ones we don't do auto on, but yes, it'll take 3. And I think if we do something with anytime it's automated, they always pick 3. You guys
Sweet.
have kind of older machines for sure.
Well, that's something to look forward to.
Yeah, you guys will definitely, this thing's bouncing around. Will definitely be surprised at what you guys can see when you're out in the real world. I think I keep thinking when I try to move things, I'm on the right slide here. Measurements. Okay, basically what we do as sonographers is we look at things in black and white, and things have to make sense. I mean, we can always go through the day where it's like we just are robots and we get this and get that and get this, but it needs to make sense to you. If you have a valve, if you have an aortic valve that is super bright and looks sclerotic, doesn't open very well, and you're getting a normal velocity across it, you have to ask yourself why, because it shouldn't be normal. And so 2D is super important to look at the anatomy, and then color should verify that it's turbulent, and then your pulse wave or your continuous wave should validate what you're seeing. If something doesn't make sense, you're probably not getting an accurate read on it. So just make sure you know what you're looking at and kind of what to expect. I'll touch up on, there's a slide that talks about low cardiac output and aortic stenosis, and we'll talk about that when we get there, but it kind of goes along with knowing that you should see something more severe than you're seeing. So normal aortic valve area is 2 centimeters squared. If you're getting, it can be bigger within the range of not being too big. And there's Z-scores for that. So basically when you have a stenotic valve, your aortic valve area is going to get smaller. And then when that gets smaller, then your pressure gradient goes up, which makes sense because it's going through a tighter area. So continuity equation you guys have all been doing. We as sonographers just get all the information, and then our machines populate everything onto the report. So the unknown is always trying to find that aortic valve area. So in order to find that, we do the cross-sectional area of your left ventricular outflow tract in the parasternal long axis. That's before the valve. It's actually supposed to be like 0.5 millimeters before the valve if there's not a sclerotic valve. If the valve is sclerotic, which has aortic stenosis, then you don't always take it 0.5 millimeters before the valve, because if it's stenotic, you'll get an increase in velocity in that area, and you want to make sure you're not when you're Doppler in the 5 chamber, you're not in that area of an accelerated flow. So if you find yourself picking up an increased flow before that valve, then you have to know in the peristernal long axis when you're measuring it to also back it up as much as you do in that aortic 5 chamber. So say you're doing a patient, you don't even notice they have aortic stenosis, and you're just going through your day and you're measuring your LV outflow tract and you measure it, and then you notice that there's stenosis, then just make sure after you do your aortic 5, your apical 5, and you see where you Doppler for that LV outflow tract pulse wave, then you go back to your peristernal long and make the measurement in that same area. Does that make sense to everybody?
Tammy,
Yeah.
was it your PowerPoint that I was reading? It was 10 millimeters back? Or was it something else? Or is that you?
No, there was something that I'm going to get to that slide. When I'll get to that slide, that's the person that has aortic stenosis. It's the one where it shows aortic stenosis and no stenosis and how to measure it. So let me get to that slide. It's coming up next. I'm not
So
quite.
how do you know you're in the same spot without?
So
is it just guesstimation?
no, you'll know when you are in your apical 5 chamber view and you have color on it and you're Dopplering, you're gonna see where that velocity increases by color, right? Same thing in the peristernal long axis. When you put color on and it's turbulent a little bit before that valve, that's not where you're gonna wanna measure it at, because that's not where you're gonna take the Doppler at. So you can actually have color on a picture that you've stored on your machine, and then you can take the color off. Or I like to do side-by-sides a lot when there's an abnormality or something. I do a black and white picture and a color picture of the heart, and I can look at the one side of the screen and see where it's turbulent, and then I can go over to the black and white picture and make sure I'm measuring in the right spot. Have you guys done side-by-sides? Have you guys done color compare on your echo machines?
No.
Okay, so when you guys have a 2D image and then you put on color, under that color tab, there's a color compare. Hit that and it'll bring up 2 different pictures, one black and white and one with color. I'll show you guys that next Monday. It's huge when you're looking at stuff like this.
And so basically that's just making sure that our conservation of mass is actually correct, like what goes in, what comes out kind of thing.
Yeah, it's basically, I mean, you know, when we do our mass and stuff, we do a cross section at the papillary level for the mass and stuff. But yes, it's basically saying at the level that I measured this velocity is where I'm measuring that same distance. Because if you're not in the same spot, then it's going to throw your numbers off and give an erroneous number for your aortic valve area. Most likely it will probably give you a smaller area if you're in the stenotic portion of it. So you just want to make sure you're in the area that isn't turbulent.
So you're measuring before the turbulence for
Yeah.
your diameter, not where the turbulence is, and not after, but before.
Yes.
Okay.
Yeah. So here's
One more piece to add on to that to make sure I'm clarifying everything. Stenosis, aortic stenosis will cause turbulence before the valve.
with the more severe the aortic is stenotic. Yes, it's kind of like a river. You know, when you have a
Yeah.
spot in a river, the tighter it is, then the faster it begins, like before it, that current. So depending on the severity, yes. And
It's the kids hanging out waiting to go down the slide.
Yep.
And you got to do it right before they bundle up.
Yep.
Okay, cool. I got you.
Okay. So this right here, I think we've shown you 100 times, is you measure your LV outflow tract before the valve. Like I've said, 0.5 millimeters in a normal patient, inner to inner, mid-systole, so the aortic valve is open. I like it when it's open enough that you can see that aortic root area kind of bulge out a little bit. And so then I just back it up from those hinge points, and that's where I measure the LV outflow tract. Inner to inner. Everything in your adult world, anything beyond that root is leading edge to leading edge and end diastole. Hi, hey Joe. And then like in pediatrics and stuff, everything's mid systole, inner to inner until the patient is 18 years old. Again, what we just talked about, apical 5 chamber, make sure you put that pulse wave. They're saying approximately 3 millimeters from the aortic valve. You know, it's supposed to be 5, like 0.5. The main thing is go before that aortic valve in the pulse wave without, pulling out your ruler and measuring it, because we can't do that. And the heart's moving, so it's bouncing. So we're not getting an actual 3 millimeters. When you see that valve closure click, you're good. You are in the right spot. I like to track my pulse wave, hit that aortic valve, and you'll see a step up in that pulse wave. It's obvious. And then I just back it further away from the valve so it goes back down. That's when you know you're not at the valve and you're in the actual left ventricular outflow tract. You're not at the aortic valve level. So pulse wave is before the valve. Touch the valve, pull it back a little bit. You're in the right spot. And then CW is going to track that whole entire line and pick up your highest velocity. Of course, you have to be careful if you're picking up a branch PA, but that just adds to your study to figure out what velocities you're looking at. Again, with aortic velocities, not always are you going to get the highest velocity apically. You may not at all. You may think I'm getting, a decent velocity, but it's not severe. And then you go subcostally and it's a little bit higher. And then you go in the neck and you're looking suprasternally at that ascending aorta area, and you're picking up a huge, huge velocity. So you take the highest velocity, you record the highest velocity, and then in your report, you write where you found it, because it's just nice to the other sonographers who are doing it, a month later, that they're not fishing around everywhere. I mean, they're going to look because that's what we do as a protocol, but they're going to know that their best window is where you recorded it. So we make note of that. It can be a high right, a suprasternal, subcostal, or apical, depending on the patient. So it's just nice to kind of record that data for the next person. Are there any questions with that? No? Okay. So this is just a picture of a pulse wave of your LV outflow tract. What I mean by modal is that bright area. It's not the wispy stuff outside of it. And so whenever you trace a pulse wave, you trace the modal velocity. So you just don't incorporate every red blood cell, because we don't care about the little strays out there. We want the modal level. We want the majority of them. We don't need to pick up every little guy floating out there. Just get the mode. And again, this just states if you see that aortic closing click, that you're in the right proximity of the annulus. This is a CW. You can tell this pulse wave 1 has that black in between, less blood cells. The continuous wave is all filled in. On continuous wave, we incorporate everything, and that's why it's super important to make sure you turn down your gain. If you don't take your gain down, then you're going to get that overestimate. Like somebody was asking earlier, how can you overestimate the velocity? Well, I can gain this way up and add to the severity of the stenosis, which is not nice to do to the patient, because it's not a legit, it's not an accurate recording. So turn the scale down, or turn the gain down, and then make sure that wall filter area, I've heard you guys playing with it today because it gets real that thumpy noise. It's just important to fill in that to the baseline as much as you can without thumping and making it distort itself, because when you're tracing, you have to bring the trace to the baseline. And if you don't have a signal to the baseline, then you don't know where to start and where to end your tracing. So play with the wall filters, scale down or gain down. I keep saying scale, but I mean gain down. So this is just showing that the more stenotic the valve, the smaller the valve area and the higher the pressure gradient. Anything less than 0.6 centimeters squared with a pressure gradient of more than 60 millimeters of mercury would be considered an extremely severe case of aortic stenosis, as depicted right here.
Hey,
in the
Tammy, it's
picture.
Kelsey. I have a question when you're finished up.
Yep, you're good.
So just after this slide here that you show of the spectral Doppler is a chart. Where did you obtain this chart? Because there is just a little bit of difference between that last PowerPoint and then the chart. Obviously, we'd probably go off of ASC, correct?
Is this the chart am I showing you right now?
Yes.
Okay. I can't honestly tell you when this one was printed. What's the new version? Is it like way off on the numbers?
Well, no, I'm just saying in comparison to the severity scale of aortic valve stenosis slide just before that spectral slide that you just showed us.
This one?
Yeah, there we go. It's about 5 millimeters off on a couple of them, but it's really not a huge difference. I'm just curious, just so that when we're tested.
1.5 to 2 for the mild.
Mean gradient specifically.
Yeah. See, this is the one I would go off of, this one, because I wrote it.
Okay, sounds great. Thank you.
Yeah, do that one. And then I will clarify before next Monday. I will make a note and make sure for the severity of the AS, what the pressure gradients, because they, like I said, they change sometimes, depending on.
I bet. Thank you.
Yeah, you're welcome. I'll go over that. And, yeah, we'll go over that, or I'll just brush up on it.
Tammy,
Yeah.
on that same vein, or artery, Scott's been saying no mild and severes. He's been holding us to those. Do you want us to also know the values for moderate and like extreme, or?
So what is Scott saying? No to one of them? I didn't understand.
We should know and understand and recognize what normal is and what severe is.
Yes. I like
yeah.
mild, moderate, and severe, but if you know mild and you know severe, then moderate's just in between.
I think what Nancy is asking is that testing wise at this point, Scott is only having us know the normal value and the severe value. At this point, he's not making us memorize all three values or something.
That's nice of him. Well, I definitely want you to know the normals, and I definitely want you to know severes. But I know some of my questions have incorporated the milds and the moderates, especially with aortic regurgitation.
Okay,
So
all.
What's that?
I said, so then you want us to know them all.
I like that, yes.
Okay, thanks.
Yep. Okay, again, this slide, you can just tell by looking at it, which I can't see because your guys' faces are cutting it all off. So I think it's around 6 meters per second, but severe AS.
You can adjust where you see us. You can slide the little slide.
I did, and then when I do that, it's been flinging like my slides. So I'm just gonna leave it because it's fine for me. See, I tried to do something and did it again. Okay, so I'm not sure if you were all there when I was showing you when Tyler was critiquing one of your guys's pictures, but my doctors always take a ruler and put it through like that, those dashes right there. And that's how you know you have to measure perpendicular to that ruler line. So they just roll it out and then you cross it and make it a perpendicular measurement. And you know you're doing it properly. This one right here says let's see, this image includes which correct techniques. So the main thing what we're saying here is that we didn't measure from leading edge to leading edge. that white, can you see my cursor on
Yeah.
when I wiggle it a little bit? So this white right here, this measurement needed to be up here on that leading edge. So leading edge down to leading edge, which is the inner part of it. So it just, and it's really easy to know what to do with the ascending aorta, because what you're looking for is its biggest dimension. The doctor wants to know, they don't want to know what it's might be like the smallest, not in this area. They want to know if it's going to tear, if you're going to have an aortic aneurysm, if it's going to dissect, right? So they want to know at its largest. So you can actually take a heart with no EKG, and you can probably get rid of the valves and just look at that ascending aorta, look at those lines, and make it when you see them farthest apart. That's the measurement you make.
So Tammy, it's Kelsey again. So why is it that we do it at end diastole? Because you would think that the largest diameter would occur during mid systole when all that flow is going through, increasing the likelihood of,
Yeah.
tear or dissection.
Yeah, this has been a thing that has changed as much as whether you lay your baby on their face or their back or their side. Literally, when I started this program, it was systolic, it was inner to inner. Now it's end diastolic, leading to leading. I do both. I do in the pediatrics, like I say, I do mid systolic, all inner to inner, and then end diastolic, leading edge to leading edge. And then you can't go wrong. They should probably be around the same measurements, but it's an ASE thing that the guidelines changed. And so, again, it's, if you're doing a baby, it's mid-systolic inner to inner in an adult. It's just a thing they change, and they'll probably change it here in 5 years from now. I have no idea. The main thing is the doctors always measure it when they see it at its largest. So,
Okay. Yeah. And we had this discussion earlier in the quarter too with Scott, because it would seem like it should be outer to outer to be consistent with other imaging modalities too. But
yeah.
as long as we know what is correct for the lab.
Yeah, and I think, like I said, it's changed. When I took the registry, it wasn't how you guys are going to be tested now, but it is. If you take your boards or your registry, it will be end diastole, leading edge to leading edge, and that's just the correct answer.
So
Okie dokie.
even though the correct answer is in diastole, you are saying that we should measure it when it's at its fullest, no matter where that is in the cardiac cycle?
I follow that aorta clear out to the head and neck vessels, and whenever I see big parts of it, I measure them. That's just what I've always done in my practice of doing echoes. But for you guys, just do end diastole, leading edge to leading edge. But if you're doing a scan and you measure the root and the junction and the ascending and 4 inches away from there, which you're not supposed to measure or it's not asked to measure, but you see something bulging, I would definitely say measure it and bring it to the doctor's attention. You won't get in trouble for it. You will if you miss it. So does that answer your question? Oops.
Kind of. It wasn't, my question was,
End diastole, leading edge to leading edge.
At what point is it called the descending aorta? They're like a
Descending-
landmark.
Yeah. So in your suprasternal notch view, when you have that candy cane look, right?
Right.
And you have your ascending coming up, and then you have your transverse. And then when it bends around, you will have your isthmus area, which is right after your subclavian artery. That is your descending aorta.
Okay, thank you. So it's kind of the subclavian, the left subclavian then.
Yeah. So that
Okay.
isthmus area, like where you get a coarct kind of in that isthmus area, right beyond that, anything going down, anytime you get that blue blood going away, that's considered descending.
Okay, thank you.
Yeah. Sinotubular junction is where after the aortic root squeezes back in before it goes into the ascending aorta. You guys have been measuring that too, correct? Yep. Okay, so was this measured correctly or was it not?
No.
No. And the reason behind that is because it's not at its largest dimension. And I don't know if it was actually leading. Yeah, it's actually probably on there. So just, I would move it to the right, even though that's to the left of our screen or however you want to say it on the ultrasound machine, but further away from that valve, actually on that root where it bulges is where you make that measurement.
Hey Tammy, it's Sarissa.
Yep.
Were you just saying that we are supposed to be measuring the sinotubular junction?
I was asking if he has you measuring it.
Oh, I did. I don't see if anyone answered, but we haven't been. Is that how relevant is that going to be in studies?
So on a normal patient, we won't measure it, but if somebody has a bicuspid aortic valve, then we measure the root, the junction, and the ascending. So unless somebody has a bicuspid valve, we won't do it. Or if somebody has Marfan's, which is a connective tissue disorder, which creates aortic dilatation over time. If there's an aortic issue like bicuspid or Marfan's, then we do the junction.
Okay.
Tammy, on
Yep.
this one, would it just be the top caliper that you would move over? Because the bottom one looks like it's probably in the correct spot.
Yeah, so if I take a pencil like this, I kind of want to, yeah, I would take the top one for sure, definitely. And then, yeah, probably just that top one.
The next slide will show the correct placement, Kathleen.
Yep. So they moved it a little bit, but then they also cleaned up the picture to where it looks easier. Because if you look back at the last one,
Yeah, that's not the same picture.
it's like they laid it out better for you. So yeah, so then they just move the whole thing over. But if you go back to this one and move the whole thing over, then you're not even on it. You're off of that non-coronary cusp.
Yeah, on this one, I would just move the top one over. The bottom one looks pretty.
But or I would just get that picture right there.
Yeah.
Yeah. And that was kind of a tricky thing. So yeah, that's at its largest for sure. And then here's what we were talking about earlier. Would the LV outflow tract diameter measurement be made at the same location proximal to the aortic annulus for both these images? And the answer is no, because the left one that we're looking at is stenotic, and you can tell it's not opening super nice right there. And so this is where there's that question, I think, of the 10 millimeters, because it will tell you right here, measuring it in the right spot. So if the Doppler cursor's back 5 to 10 to avoid that pre-valvular acceleration like we were talking about earlier. So it's not, the answer is no. A normal healthy heart versus a stenotic valve, they're not going to be textbook measurements 0.5 or 5 millimeters before the valve. It's not going to happen because there's going to be that pre-valvular acceleration that you want to avoid.
Hey Tammy, can we go back to that last slide with the picture? And can you just, because I want to confirm something on the right side with no stenosis.
Yep.
Can you just put your cursor where you would measure your LVOT?
About right here.
Okay.
Yeah, so here's like the hinge point, like right here. So I just go back to there and go down. I don't love this picture because this almost looks like mitral valve right there. And you don't want to be out on that leaflet, but if here's the hinge, you just go 5 millimeters back and then go back down. But I don't love that picture so much. I definitely, this is one that you have to make sure that you open, like I will freeze it and I'll play it back and forth and back and forth. It's really hard to tell on a still picture, and then you can see where the leaflet's open.
Where
Yeah,
would you measure on the other picture?
yeah, you're gonna have to, you're probably gonna be back up over in here down to here in this area right in here, because there's probably some pre-acceleration right in here that you don't want to measure. I'm assuming you're gonna be Dopplering back here, so it can actually be back to here and here.
So further into the LV, you want to measure.
Yep. Yeah, and again, you'd have to look at that apical 5 chamber and see what where you took that pulse wave from. Here's a little video that we're going to play for aortic regurgitation. So you guys can all see the AI right here. You see that little blue wispy thing right there? Oh, there it is. So that's just a look at AI. It's obviously blue and moving away from the transducer during diastole, but that's actually also kind of a not so awesome machine, kind of what you guys might be used to. And then I know, right? And then they'll show you right here too. It's going to be actually coming towards the transducer. It should point to it for you. So, am I stopping that? There it is. So it's coming towards, so it's red during diastole. And then with that color box, I would have moved it probably over a little bit just to make sure. Hold on a second. I have to stop moving my thing. The color box over a little bit just to make sure you're picking up that whole entire jet. And then when you Doppler it, that waveform is going to be above the baseline, which will be the next little thing they'll show you. That's just your normal aortic flow being blue. Do you guys have anybody in the class that has AI? I know we have a bunch of MRs and TRs, but I don't think we have any. There's AI right here again. This little spot right there. That's your subcostal.
My grandpa has mild MI, and I'm pretty sure the class viewed it one day when I was scanning.
Mm-hmm. Okay, so, and again with AI, we're going to see, so right here above the baseline, you can see my cursor, right? Yeah.
Yes.
Okay, so above the baseline, this is obviously the AI. I would have liked this baseline to be moved down a bit because we're cutting that off. It's really easy to not get the whole aortic regurgitant jet. Pressure half times is kind of the same. Like if somebody has pulmonary insufficiency, the more pointy or steeper that is, you're going to have a less pressure half time and it's more severe. So I wouldn't even be able to get a pressure half time off of this one because it's not giving you the whole envelope there. So, but the AS, again, this was CW, so we incorporated all of it. Again, you can probably take 3 of those measurements. But we like, I don't know who I showed earlier today, but I like to get both of the waveforms in one clip when I can, but then when I'm going to do the measurement, then I exclude the one I don't need. I like to show the doctor both of them together, but then when it's just the AS, then I'll bring the baseline up and focus on that, drop the scale, make it take up the screen. Same thing with the AI, drop the baseline down. Sometimes I take my sweep speed and I make it longer so it draws that out more so that you can understand how to do that pressure halftime measurement. So just depending on which one you're looking at, accentuate like that actual waveform and then go with it. But both of them together are always nice too to show them.
And Tammy, this was sorry.
Yep.
That last picture, that was a good example of when we were talking about having stenosis and regurgitant in the same one, right? When you were talking about there's not going to be that space.
No.
Or is that just with?
Nope, because this isn't showing any MR.
Okay.
Can you guys see? Can I stop sharing? Let me just get through this and I'll show everybody what she was just talking about with that IVRT, the AS, and the MR, like I showed you that drawing on the blackboard the other day. I'll pull it up.
Before you, I would appreciate that, but before we do and we leave this slide, is it overgained maybe and then over measured on the bottom?
It does look over measured there. And the thing that's really hard, and this is why when Tyler critiques you guys, it's kind of brutal because on the machine, it looks differently than how it comes over on the reader. And so I've had doctors come in and wonder if we measured it right, and then you pull it up on the machine. So it does look overgained here. However, on the machine, maybe it was a little bit different. But yes, I would definitely take that in. I don't think it's so bulbous there at the end like that person swung it out.
But Tammy, I thought with continuous wave, which I assume this is continuous wave, you do measure the little
you do
brightest parts.
You do, but look at the other ones next to it, and they're not as much. So it just looks like it's more swoopy at the bottom than it probably should be.
Okay.
But it is incorporating everything. And like I said, on the machine, it's a little different than how it comes across. But this is kind of splitting hairs on this one because it probably, they did incorporate everything, but it could be a little bit overgained. It's hard to tell on a still picture. So, but according to the other ones, they don't look nearly as much. This basically, is kind of a crazy slide. I'm just showing that it doesn't have the moderate. When I do AI, I visually look at it. I look at its like the vena contracta. I don't measure it. We don't measure it a lot in kids. We do pressure half time where we do the slope. And so I just know when I'm getting a pressure half time of over 500, it's considered like mild. If I'm getting under 200, I'm getting a severe steep slope, and it's severe aortic regurg. But then we also look for flow reversal in the descending aorta. We'll look for it in the abdominal aorta. And there's a whole lot of factors that go in. So when I test you guys over this, my main thing is going to be like, know the pressure halftime. And then I won't throw in the moderate there because it's not on here, but obviously moderates, it's just not on here. So don't worry about it. But I do the pressure halftime, and then obviously you guys, I believe, have been doing the vena contracta too.
No, we
the
haven't.
biggest-
Not.
You haven't been.
So the biggest things to measure with AI are the VTI and the pressure halftime, the vena contracta sometimes, and then the EROA.
Yeah. Yeah, we have like I said, yeah, we're huge into pressure half times. So we have to get that whole CW Doppler on there. But the vena contracta width, obviously the bigger it is, then the more it's leaking. But then we also take into consideration, the ventricle. Is it thick? Is it dilating? How long has it been going on for? So so you can overkill and go into a bunch of stuff, but yes, with aortic insufficiency, make sure you get a good CW, look at that aortic insufficiency jet, and always make sure that you have the color box. Is that all? Showing exactly how far that that jet's going. Don't ever cut it off. I think I lost my conclusion here. Oh, there it is. You guys already watch this video?
You know, in your PowerPoints, they actually came across as pictures.
Okay, so here's the mild. Let's play this. Mild AI. Yeah. So see the blue going away right here? That's AI. Again, I would take that color box and bring it more into the ventricle to see how far back it's going, but they're going to do a vena contracta right there, neck to neck. It's a beautiful look at the aorta. And so we're showing black and white of the aortic valve in the peristernal long, color in the peristernal long, black and white picture at the short axis, color on the short axis. Anywhere we can see this aortic valve, I think they're trying to show a 5-chamber, kind of looks like poop. And then the AI is right there too. So black and white and color. Again, there's your 3-chamber, black and white, and then color. And I'm not sure. So that's the AI that I said you measure. You have to get that total. That's a 745 right there. So it's mild. It's over the 500. And there's a subcostal look. There's your descending aorta, all that blue going away. They're looking for any flow reversal in their Dopplering. So anything aortic related, you look at the aorta in every view you can. And it's important I would have also looked subcostally at your aorta, your abdominal aorta, because if somebody has severe AI, you'll pick it up there too. So super important just to look at all of the pictures that you can see the aortic in. Conclusions. So What's that?
I have a question.
Yep.
Does the same hold true for the flail leaflets with eccentric jets? Like usually if there's a culprit flail leaflet, the jet will direct the different, the opposite way, even with
And
the aortic valve?
From the aortic. Yeah, I mean, you can have a prolapsing valve and it'll direct away from it. It's harder to quantitate kind of those eccentric jets more than the central. Is that what you're saying? Is it because like we were talking about the mitral valve, when it prolapses, the regurgitant jet goes away from it?
Yes, yeah.
Yeah, yeah, holds the same for the aortic valve. This is just stating right here, it kind of protects your butt as a sonographer to always do a CW, I believe they're saying. Dropping a CW across the aorta. I guess I'm thinking you guys haven't seen membranes in the LV outflow tract. So before that valve, which would be considered subaortic, it's called a subaortic membrane because it's before the valve, and anything after the valve is supra. So you'll get a little thing that looks like it's hanging down from the interventricular septum, and it will cause subaortic stenosis. You may not see it in the parasternal long, but in the apical 5 chamber, if you Doppler and you pick up some type of step up in gradient, then you have to be concerned where that's at. If it's before the valve, what's causing that before the valve? If it's not a stenotic valve, then why is there a step up? It's probably some type of membrane. So it's just pretty much saying drop that CW. And it's okay as a sonographer if you don't see something initially and then you see it, to go back and then say zoom in on a parasternal long to try and find that membrane. I'm going to stop sharing that screen so that we're back. I wanted to show, so you guys can see, if I show you a picture, this is not going to be the best, but I will try and see if I can post it maybe on Canvas for you guys. But I did a patient the other day that had, a good amount of MR. And so I call it a blackboard, but I guess it's white now or something. In class, when I did that drawing, I showed the IVRT and the MR and the outflow tract, and I said that I'd get you a picture of it. Can you guys, let me see, hold on a second. Can you guys see?
Yeah.
Okay, who went away? You can still see that? Okay, so there's a, when somebody talks, it goes away and I can't see it. There's that bright area below the baseline, and that's your LV outflow tract. That's your gradient across the outflow tract. The other stuff right here, this is your MR. Now, this is probably me backwards to you guys. So I'm going to post that on Canvas so you guys can see that I overlapped both the MR and the outflow tract gradient, and just kind of shows you that the MR takes right off from that E and A of the inflow. There's no IVRT.
Kemi, it did show right. It showed the way you showed me in lab today. This was
Okay.
Nancy.
Can you guys see that?
Higher. There you go.
So see all that not so in stuff, that's the MR. I don't know if I can do another picture. This one's not going to show up as well, but you can also see them both kind of right there as well. The LV outflow tract and the MR. Just showing that if you guys are trying to figure out if someone has severe AS and severe MR, the MR needs to be systemic. So it should be higher, but not always, because if somebody has really elevated left atrial pressures, then your MR will be less than, or if somebody has low blood pressure, that gradient, that peak velocity will be less. And so it actually could be the aortic stenosis being more. So, but it's good to see both of them together. And then throughout your exam, you'll know which velocity you're dealing with. It gets tricky when they get on a treadmill. So, but I'll try and post that so you guys can see it, because I would put that on your quiz. Like I'd point to one of the waveforms and the other waveform and ask you guys to label which is which. So are there any questions at all? Are you guys all okay with 12 to 4 next Monday for your quiz? And we can go over when I'm there Monday, anything you guys have questions before when we're in lab, any questions to clear up anything. But just go over the PowerPoints that I've given you, because I'll just take the questions off the PowerPoints and possibly like what we just discussed right now. It's good to know when to measure things, outflow track, I want inner to inner, mid-systole, and anything on the other side, you guys measure end diastolic, leading edge to leading edge. Pulse wave has the modal velocities, continuous wave, you incorporate everything. Don't overgain, because that will, give you an erroneous high number. Pulse wave site specific, continuous waves not site specific, but the differences between them, pulse wave is going to alias, continuous waves not. Just the fundamentals of all the PowerPoints will just be fair game.
And then Tammy, I did have a question to ask you regarding the other PowerPoints. How possible is that to get those uploaded to Canvas?
I'll do it.
Awesome. Thank you.
Yep. So I've done the aortic, so we just need the mitral valve and tricuspid valve and the color one. Tricuspid valve and the CDI. Okay, so I'll upload all those three. If I find interesting pictures, I'll try and upload those as well, because it's easier than showing you my phone. And so we won't have a meeting next Monday, but then the following Monday after that, we'll go over the pulmonary valve.
And as far as the delivery of that Zoom link, could you please also post that in Canvas as an announcement or something, or is it the same one as this one?
No, I always do new ones, but you won't have one for next Monday.
Right, so it's the following one. I don't know, for some reason, I'm not getting your emails. And maybe they're not coming to you either, because I sent you an email a couple of times about last week.
Can you tell me your email, or do you not want anyone to know it?
No, it's fine, and I'm included in the list that you sent this morning. It just didn't come to me.
I don't understand that.
I don't either.
Is Mike? He knows, right?
Yeah, it's you're not in my trash, you're not in my spam, it's just not
saw your
getting it.
name on the email.
I'm sorry?
You saw your name on the email.
I saw my name when somebody showed me their list, and I was the recipient, so
it's not my fault. Just kidding.
No.
I don't know. Yeah.
I don't know.
Can I post that on Canvas? Oh, I guess I can copy the link and then go back into Canvas.
And just share it as an announcement.
Copy link. Is there anybody else who's having a problem getting my evites to Zoom? Okay, so just you. All right, I'll copy link to Canvas.
Thanks for doing it just for me.
No,
Casey, are you able to see the class in Canvas yet? If she's here.
Oh yeah. Yeah, I'm
Oh,
here.
good.
Yeah, I can.
Okay.
But everybody else can see the aortic presentation in Canvas. So May 17th will be the pulmonary valve. I will just set up that Zoom for 2 to 4. I would just put 3 because we're practically done. And I'll just get that going. Probably not today because I have crazy stuff to do, but I'll get that going so you guys have it. And I'm still working on the quiz. Yeah.
The final for this class is the 14th. Is that correct?
Yep. That's Flag Day. Yeah. So quiz, pulmonary, hepatics, then you have Memorial Day for nothing. And then, yeah, I'd like to try and do one more quiz. I have to sneak something in there. Because
And the final is in person?
I don't know if I have to do it in person yet or not. If I don't have to, I probably won't.
Okay. I have a question going back to the slides.
Mhm.
How common is it to see a subaortic membrane? Because it seems to me like it might be like a birth defect thing.
Yeah, that's a good question on the adults. Maybe you don't see them as much. I just know once you have one and they're resected, they come back. So I don't know, some people are just prone to it. So it probably is some type of a congenital.
Okay.
Yeah.
And then going to the wall filter subject when it comes to tracing your VTIs. So you want a lower wall filter so that way you can see the waveform to the baseline, or you want a high wall filter so that you get rid of all that noise near the baseline.
No, you want a lower wall filter. So
Okay.
it brings that noise to the baseline, not too noisy so that it noises out on the wrong side of the baseline and gets thumpity. But yes, you definitely want to fill in that black. Those presets for those machines are way too high. Like the HP 5500 has a wall filter at 500 and we bring it down to like 200. So a littler number wall filter.
Okay, and then do doctors like frown upon you increasing your sweep speed on all your waveforms? Because sometimes it's easier to see all your waveforms at an increased sweep speed.
I take them all at 100 because that's what they want. And then it's a post-processing thing. When I'm done with it, if I'm making a measurement, I will toggle through and make the waveform fill out more. But I don't show the doctor that moving one like that. I keep it at the 100. And then I can do
Okay.
the measurements differently.
So you can change the sweep speed post process?
Yep.
Not on all of our machines, I don't think.
Yeah, not on the dinosaur.
Yeah, we can because I do it all the time.
Good to know.
I'll look
That's
at-
nice.
Yeah. You can also do, when you guys are doing PISA, you can just drop your baseline scale and all that and turn it down and zoom in and then do all your stuff afterwards too. You can also do TAPSY afterwards. You can drop a cursor post. If you have the picture, you can do every TAPSY and MAPSY thing you want without even having an MO through there. You're like, oh my God, I forgot. Drop an MO through it and get it done.
It'll be nice to go to a lab.
Yeah, machines are a little bit better then, so.
You can do that in
What?
packs or you're talking on the machine?
I go back to the machine. Yeah, go back to the machine and I'll pull up my apical 4-chamber and then I'll push M mode and it takes a while to track it over and I drop that cursor and I put M mode on it and then I invert mine and then I have my TAPSY. We don't do MAPSY at all. I don't know anyone who does, but we do TAPSY. For our left side stuff, we'll do like change in pressure over change in time for MR. We do lateral E and septal E and all that stuff, but we don't do a MAPSY. So.
Okay, one last question. I'm sorry.
No, you're good.
It's kind of off topic-ish. So it was mentioned in the slides that it's frowned upon to use angle correct in the aortic valve because it's just 2D doesn't account for that. Or it's only accounted for in 2D. But I was asking Tyler, I was like, what if I can't see my right lower pulmonary vein with an apical 4-chamber, but I can see my left upper coming in really good? Can I pulse wave there? And he's like, yeah, that's fine, just angle correct. Then there's the angle correct thing.
We don't, so cardiac wise, we don't angle correct. Like period. They say in those slides, yeah, it's like do it for your own knowledge of what it can possibly be, but I don't even know, I don't know any sonographers who use the angle correct. And I'm not sure why would you angle correct if you're Dopplering in a different vein. You're Dopplering in a different vein.
Okay.
So why are you angle correcting? Because you don't think you're lined up well with it?
Yeah, I think he mentioned the angle correction because it's obviously coming, or not, I guess not obviously, but it's coming in at a different angle versus the straight up and down angle that you would be able to get with with the pulsed wave there at the right lower.
I move the heart, like I put that heart anywhere I want on that screen. And before I go into an angle correction on a, I'll just swing the heart and line it up differently. Or, if you wanted, you could Doppler that right upper from the subcostal kind of by bicable. It's always there too. But yeah, you should always be able to get that right lower brought in. But I've Dopplered the left before, but I'll swing the heart. I don't, none of us, I don't think like the angle correction, but we can play with it and see what it does.
Okay, thank you.
Yeah. Are there any other questions? A bunch of black boxes around faces because nobody wants to show themselves. All right, so next Monday, 12 to 4 will be your quiz. It'll be opened. It will be timed. I don't know how many questions yet. I will try to do it so that we don't lock them once you answer it, so you can go back. But typically what I've been informed to do is 1 minute per question. So if there's 20 questions, it's 20 minutes, but I like to throw in a few extra just for the people who freak out with quizzes. I give a little bit extra because I know my daughter freaks when she's timed. So if it's 20, I'll probably give you 25 minutes. 5 minutes just to absolute brain fart and freak out. So that extra 5. But,
Dan, when you
yep.
set the quiz, can you mark it so that we can see all the questions at once, please?
Yeah. Okay. All at once, timed.
Oh, and we, so far in this program for us this year, we've been taking all of our tests, including our finals online.
Okay, good to
But I
know.
don't know what, just so
Yep.
you know, that's what's been going on.
No, that's fine with me. I had to give I think the pediatric class last year or whatever in person because we didn't want cheating or something. So, but it shouldn't be a problem. I can
Hey,
do that.
Tammy.
Yeah.
With our recent discussion about seeing coronary arteries a lot better on pediatrics, I know my cousin has some sort of coronary artery displacement or anomaly. How comfortable would you be if my cousin brought her in, because she's fine with her being scanned, scanning her maybe on a like outside of everybody else, and then having us discuss it in class or something?
Yeah. Did she have like an anomalous left or anomalous right? Did she have something to where it was corrected? Because now it's probably normal.
So she is due to have surgery. I
Okay.
don't know where the anomaly is. I just know that she's at risk for sudden
Cardiac arrest.
death. Yeah.
Yeah. So she probably has like an anomalous right. A lot of times it'll come over off that left cusp. And so it's probably just, they're going to retake it off and put it towards that right cusp because it's probably coming off the left. I'm thinking, I don't know. That's what we see a lot.
Okay.
So,
Okay. Thank you. Yeah.
Yep.
I'll try to set that up with you sometime.
How old is she?
Oh, I want to say 5.
Okay. As long as she's not, I mean, you get a 2-year-old.
Oh, no, she's well behaved.
Okay. Perfect. So how'd they find that out? Was she like, is she active and did she, or she's
I don't really know. We vaguely talked about it. I was just like, oh, I was like, doesn't she have this? And she's like, yeah. So I really don't know if she's had an echo before. I almost wonder if she's been scanned by you.
Oh,
So
what's her name? What's her name?
her name's Rose, or no, not Rose. It's well, I guess, sorry, she's got a legal name and then a not legal name. So I think it would be Shaylani Gussler.
Okay.
But yeah, she's totally okay with it being for education purposes. But
Yep.
yeah, I'll set that up with you sometime if we can.
Yeah, that'd be awesome. Perfect. Okay. Any other questions? Okay, so I'm gonna go with no. All right, guys, good chat. We'll talk next Monday at lab and answer any questions before your guys' quiz. All right.
Thank you.
Yep.
Thanks.
Yep. Bye-bye.
Thank you.
You're welcome.
Thank you.
You're welcome.